I'm Dr. Anthony Kaveh, and today we're going to talk about the fallout from Marco Tropper's recent death, 19-year-old who was found dead in his Berkeley dorm. Absolutely tragic event. And I got an email a few days later from the assemblyman in my district in San Francisco, California, Matt Haney. I'm going to show you that email in just a moment. But we're going to talk about the ethics around Narcan and what I feel is a sense of profiteering around a tragic epidemic. Marco Tropper's death is just one of many. So just as a reminder, please keep the Q&A respectful. This is live and we'll answer your questions at the end. But this is going to be a compassionate but pretty hard debate. The first thing that you need to answer for yourself before you even stick around for the rest of this video is, do you believe human death is bad? Hopefully you believe yes, so we can continue. The next question is, do you believe that preventable human deaths or self-inflicted human deaths are bad? And this includes everything from kidney disease to fatal strokes or heart attacks, suicide, and yes, addiction. Back to Marco Tropper. Whenever we're looking at individuals who are dying in medicine, I think it's important to look at the causes, how they're preventable, and then how do you act in the acute crisis, whether it's a heart attack or an addiction overdose. So in the case of Marco Tropper, we do not yet know the formal official cause of death, but for reasons you'll see in a moment, we strongly do believe it is related to an overdose. Chart here shows data about overdose deaths. Now, if you look at what I've circled in red here, those are the opioids. So there are other causes of overdose deaths, whether it's meth or cocaine or other substances. Those are important, but opioids are really at the top. When we're looking at pediatrics or young adult deaths, the most common are what we call it, I'm not saying it's the right word or not, but we call them drug, sex, and rock and roll. Most deaths in young individuals who have passed the age where genomic or metabolic deficiencies are going to cause death, most of these deaths, therefore, because we've excluded them, involve something involved in the environment. So whether it's drug, sex, or rock and roll, yes, there are some rare conditions that still persist. Sudden cardiac death from hypertrophic cardiomyopathy, long QT syndrome, etc. But by and large, these are deaths that are preventable due to accidents, and often mental health is a key part of this. Another big part, especially for the mental health, is loneliness that we do not talk about, especially in the context of pushing Narcan to address overdose deaths. So this is from a recent Gallup poll. I'm really happy they shared this data. I'm going to highlight two different parts to this graph here. You'll see the red that shows young adults versus older adults and loneliness among them. It's not rocket science to see that younger adults, about almost half of them, are reporting some level of loneliness, whether it's a little lonely or very or fairly lonely. Compared to the older adults, you'll see that the blue bar goes up. The blue bar is representing not lonely. So if you look at the little arrow I put, you'll see that younger adults seem to have more loneliness. This is really important, and we don't talk about it. It doesn't really make a lot of money, unfortunately, but this is the email I got from Matt Haney. Now, I'm not saying Matt Haney is a bad individual. I'm sure he is well-intentioned. I don't agree with many of his policies, but I want to give him the benefit of the doubt. We want to find common ground. When I get this email and we're talking about recent opioid deaths, Marco Tropper being just one of many, I can't help but wonder this push for adding naloxone to every first aid kit in the state. Is that really addressing the root cause when we're looking at causes and how you act in an acute crisis? Well, you got to look at money to understand a lot of these choices. I believe there's, like most things in medicine, a paper trail. A 2-dose pack of Narcan is about $45. Hopefully it can be obtained for cheaper. I have nothing against Narcan. To be very clear, I am not anti-harm reduction in this instance, not at all. But we have to acknowledge that Narcan raked in $1.44 billion in a 5-year period in the opioid epidemic. This is important medication. There are significant costs, not only the Narcan, but training people on how to use them. Last year, Matt Haney wanted to put forward a bill that would require Narcan to be in many public environments, like libraries, etc. That would have cost hundreds of thousands of dollars. It was AB 24. It didn't make it through. This year, he's pushing for adding naloxone to every first aid kit in the state. These are kind of attempts to reach what's called naloxone saturation, meaning that you have naloxone everywhere. Naloxone is simply the generic name for Narcan. And I have nothing against spending money in medicine. Quality of life, or QOL, matters. And let's face it, medicine already costs 18% of the United States gross domestic product. That's absolutely huge. There's nothing wrong with spending money to save lives, nothing wrong with spending money to improve lives. This is the reality of the world. But is it right to make naloxone so saturated where you have vending machines literally with Narcan, like you see here, while not addressing the loneliness that is more prevalent, that can lead to these deaths, that Narcan cannot fix? Because when Marco was found dead alone in his dorm room, was he going to give himself a naloxone spray? If we're lonely and we're overdosing, are we really addressing the problem by just shoving naloxone in every first aid kit in the state? Are we doing justice to our patients, to our loved ones, to their family by not addressing the elephant in the room? Well, let's look at heart attacks, another major cause of death. Heart disease is the #1 cause of death worldwide in adults. Well, there's causes of heart disease and cardiovascular disease, and quite frankly, so many other diseases. We know so many of the causes. Now, there's some debate in some of these, but whether it's addiction to gambling, or it's diabetes, or it's risk of overdose from an addiction, or not having the right mental health, maybe from loneliness, you got to look at these and ask first, are we addressing any of them? And yes, I did put dealers at the bottom because this is a huge charged area of debate and controversy, whether we should be charging dealers with manslaughter. But that's not the topic for today, though we do need to think about it when we're just paying exorbitant amounts of money for Narcan everywhere. Are we addressing root causes? But let's keep going. In the acute crisis that every medical provider needs to be aware of, and quite frankly, if you're a family member of a loved one or a friend who's going through a crisis, what do? Looking at heart attacks, because guys, this is not exactly uncommon, right? You have to take them to the emergency room. They'll place a stent like you see here in the photo, and then you have follow-up care. If someone's having a stroke, you rush them to the emergency room so that they get what's called TPA, tissue plasminogen activator, to help break up the clot if it's that type of stroke. If it's a different type of stroke from bleeding, there's other measures you have to take with blood pressure control, but you have crisis protocols that you follow. What do you do after the crisis is part of crisis management. And this is where a naloxone saturation falls completely short if that's where we stop the discussion. When someone comes in with a heart attack, they get a stent in their heart, hopefully. They'll have an echocardiogram done, an EKG. They'll be given some sort of blood thinner so that the stent stays open. Plavix is a common one in the United States. Oops. And then you follow up with the cardiologist. FU is not an inappropriate FU. It stands for follow-up in medicine. You follow up with the cardiologist. If you have a stroke, you have a CT scan, you push that TPA, you get the EKG, you may be on aspirin for the rest of your life. You follow up with a neurologist, or at least with your primary care doctor. What about from an overdose? So you give Narcan, got it. You give Narcan again because Narcan has a short half-life. Okay, meaning you have to redose Narcan until you have let the opioid that you're trying to reverse completely metabolize out of the system. But what happens after? Does anyone ask what happens after? I mean, after all, heart attacks, you have a whole post-crisis that you have to go through. For the stroke, the same thing. What about overdoses? Is the Narcan vending machine solving the problem? What if it's not even opioids? What if it's from xylazine or cocaine or an Amazon shopping addiction or gambling? Are we addressing the root causes of these devastating mental health conditions that can ruin individuals and their families by just shoving naloxone everywhere? This is a huge question about civil liberty. No question about it. And I don't even need to go into that to raise the unfortunate place that we are stuck, possibly profiteering off of Narcan. Certainly, Narcan makes a lot of money. Certainly, politicians play a huge or make a huge platform off of pushing for naloxone. And I'm not saying it's wrong to push for naloxone. It truly is a powerful, powerful drug. It's not new by any means. There's, of course, ways that drug companies try to keep patents on it so they can charge more money. And that's a whole different discussion that we're happy to talk about, to keep those costs high so they can bring in money, which they're entitled to bring in money, but up to a point. I hope we'd all agree. But when Matt Haney calls Narcan or naloxone, the same thing, a miracle drug, yes, it's a miracle for that acute crisis, but it's not the miracle solution to the opioid epidemic or to the addiction epidemic or to the loneliness epidemic. Harm reduction has the word harm in it, guys. It's not a panacea. Just because we're reducing the harm, which is powerful and we should be doing it. Of course, naloxone is powerful, but it's still harm. The opioid epidemic is still harmful, and loneliness is absolutely harmful. Well, I want to get to your questions. Just want to remind you that if you're learning something new, do please hit that like button and share what you've learned with your loved ones and your family members. You have incredible power over your health, and by advocating and encouraging empowerment versus victimization, which is unfortunately easy to do when our mental health is challenged and we fall into instinctual responses and coping mechanisms that aren't well thought out because we're in crisis situations or we're in survival mode. No, that's natural, but we don't want to be celebrating victimization. We want to be encouraging advocacy and empowerment as much as possible. So I want to get to your comments. So many questions coming in. Drug dealers will do anything to make a quick buck, Caitlin. Well, probably. We have a national untreated pain crisis. Absolutely. Addiction independent, yeah. And there's no question that the opiate epidemic has made life for my patients so challenging. Narcan OTC, Alexis says, yeah, that is the reality in many states across the country. And I don't think there's anything wrong with that per se, as long as people know how to use naloxone. Holly says they have a Narcan vending machine at our county detention center. Great. Do you guys think that's a bad move? I'm very curious about what you think. Many don't think it's a wrong move, but it's not sufficient to solve the problem. Necessary, but not sufficient. So what is being done in place of Narcan profiteering? Are we making healthcare free for everyone? Well, we need to not only have naloxone be available, but we need to also acknowledge the loneliness epidemic that is probably contributing heavily to its existence. I've seen opioids, but I've never been hooked. I've had opioids. I've been hooked to them. Well, I'm happy that you had the right internal and external support to allow for that to happen. And this is really, really important to make sure that if we are, for example, after surgery, taking these medications, that we have the right support to minimize the risk of this turning into an addiction. The Ladybug Gem says, dude, you're scaremongering. I highly disagree. What part of this is scaremongering? I'd really want to know what part of this you feel is scaremongering or not addressing the total picture of the loneliness epidemic. I encourage a debate. I hope that it is respectful, though, and I hope it's not scaremongering. Please do let me know. Ann Turner, it was never a prescription crisis. Illicit fentanyl poisonings. This is certainly a big concern. Shannon says, it would be amazing if ketamine IV infusions were a first option when seeking emergency mental health assistance. Yes, addressing root causes would be powerful. This is why I had to leave parts of the conventional medical system, if you will, because I have been able to offer this for my patients, and I find that it is transformative by addressing the root causes. Good afternoon, Morningstar Story. Alexis says, I don't think it's bad, but it can send the wrong message. People will abuse drugs knowing they can easily access naloxone. So this is a fascinating question, and it goes very closely with this latest comment. The government is not interested in fixing the core issue. So when we prescribe medications to patients, patients change their behavior. When they get blood pressure medications, they are less likely to take on lifestyle changes that might lead to weight loss, for example. There's something psychologically about knowing that there is a medication and then possibly disempowering you from making those changes yourself. So, to Alexis's point, whether this is the case for Narcan or Naloxone, it's certainly worth considering strongly, even if we don't have the exact evidence yet to prove that connection. Brittany, I really appreciate your kind comments and support. Thank you so much. My doctor friend thinks stupidly undertreating pain should be a court-martial offense for doctors. Well, yeah, there you go. If only the medical system could keep up, or the legal system could support doctors in that as well. I agree. I take hydrocodone every day for my pain. I don't abuse it, but no, physically I am addicted. And I'm sorry that you're in that situation. This is where multimodal pain management that acknowledges that emotional pain is usually inevitable once there's been enough physical pain. If you can't address one, you can't address both of them. You have to address one to address the other, and vice versa. I'm so sorry to hear about that, Laura. I hope you have the right support system around you and a careful and conscientious doctor to help you in your journey to heal. Jonathan Molina. After an injury in 08, I got hooked on opioids. It turned to a street addiction. Been clean for 10 years from heroin. It's one of the worst. I am so impressed by your vulnerability in sharing that, and I hope that you can advocate for others to also help overcome their demons. It burns me that pain patients suffer with nothing when anyone willing to break the law can get enough illegal drugs. Well, I do hear you on that. It's very frustrating. I agree. People have been doing drugs since the beginning. Yeah, cannabis has been in human use for thousands of years. Alcohol fermentation for so long. Of course, there's no question about that. It's how the human brain operates. It's silly to think that we can progress past the basic functioning and weaknesses of the human brain. One thing I disagreed with you is that you said there is, in fact, continued follow-up care after an overdose, such as rehab counseling. No, there is not. There is not. Skater, surfer, snowboarder. I'm saying there is not appropriate follow-up care. That's the issue. There is not the same level of attention that we give as medical providers to overdose victims than we do to those with heart attacks and strokes. And that is my beef with this current naloxone end-all be-all strategy that is what politicians are often pushing for. We are not giving adequate resources. They are not cost-effective. And this breaks my heart, and I hope it does yours as well, so that we can do something about it. I hope we're on the same page for that, skater, surfer, snowboarder. They prescribed me opioids even when all I needed is OTC. Well, this is a big problem across the United States, which prescribes more opioids after surgery than any other country in the world by a huge, huge margin. And I hear you about the lesser of two evils, Zsara. This is a real problem that so many of our patients face. I ended up from a TM from a V, Morningstar. I don't know what those stand for. I'm sorry. Is there anything like naloxone that works for benzodiazepines? Yes, it's called flumazenil, but it has to be used very, very carefully. Otherwise, it can cause seizures, and lethal seizures at that. I heard from a first responder, they were called to a site where someone had OD'd. Someone had inserted ice in their behind, and the victim woke up from the overdose. How is this even possible? I'm not aware of this being a possibility unless they are so, if you will, lightly narked, or they have such a low overdose level that that level of stimulation will wake them up. So, for example, in the operating room, when someone is having respiratory depression for maybe having just a little bit too much opioids on board, it's not like 0 or 1, you're overdosed and you're dead. Respiratory rate begins to go down slowly with opioids till eventually you become what's called apneic, and you just stop breathing. Apnea, like sleep apnea. Apnea. A means without. Pnea refers to breath. Pneumo from Greek. Apnea means without breath. So eventually you will become apneic. But if you're still breathing a little bit of stimulation, like maybe sticking some ice up the behind, or what we do in the operating room is a jaw thrust, is enough to stimulate breath, even without naloxone. Though, of course, naloxone is absolutely necessary in many, many cases. And Dean, I'm with you 100%, congratulating Jonathan on his challenging, challenging recovery, but his ultimate success. Should people be using medications or meditations? I think you meant medications. Be aware of the side effects for why they are using them. And well, this goes into informed consent. Of course, side effects of medications need to be told to patients. There's no question about it. And I hope that you are brave enough to ask your doctor about all the risks and benefits and alternatives to any treatment that they recommend to you. Carl Hart. I don't know enough about them. I'm so curious to read it more on them. Thank you. Not only does insurance need to cover ketamine IV, yes, but also for pain. Absolutely. I agree. It is very powerful for that. And there's no Narcan for ketamine. You're right. Um, Adequate follow-up care that is not well accessible after opioid. Yes, after those crises, I agree. It is not easily accessible. And we do not acknowledge it the same way we do for patients that have other diseases that we accept more in Western medical practice. Are there ongoing stigmas around overdose and addiction and loneliness? Of course there are. It's why the US Surgeon General had to have this giant announcement last year about the loneliness epidemic that most of us have never heard about. I'm trying to keep up with all of your questions. If you're learning something new, don't forget to hit that like button and remember to join our exclusive access for the private Zooms where we get to answer more of your questions in a much smaller group setting. The link for that is below. I agree with IV ketamine for pain. It is revolutionary in many ways. A question about anesthesia. Why do I cry and get depressed after? I'm not a person who cries much. Well, it's not a bad question at all. It's when we have the loosening of the inhibitions that ordinarily prevent us from crying or keep our emotions regulated. When that's removed, either from the stress of surgery, the pain from the incisions, or from the anesthesia itself that disinhibits the frontal lobe, all sorts of dysregulated emotions can come out, but also many healing experiences can be had as well. When you get addicted to pain pumps, depends on what's in the pain pump. If there is not an opioid component to it, it's not likely to be addicted, though, of course, dependence and all sorts of quality of life issues can come after. Great question, Heidi. Can someone OD on ketamine? Absolutely. Some words I can't use. Oh, I hear you on that. I just don't know what you're referring to. I'm sorry, Morningstar. I'm curious, what do you consider to be adequate follow-up for overdoses? Depends on the agent. Very good question. And depends on the root causes. If someone has an overdose from being found alone in their dorm, raises many questions about the mental health, whether it's depression, loneliness that's contributing to it, anxiety, maybe some level of PTSD. If it's overdose at a party or a rave with all sorts of drugs that aren't supposed to be used, well, maybe there's peer pressure influences. I mean, that's a whole entirely different scenario. If it's someone with chronic pain who's found apneic, meaning they're not breathing because of their prescription opioids, well, is it because of the pain that's not being treated appropriately? Is it that with an acute stressor, maybe from a psychosocial stressor, an interpersonal issue? I mean, who knows? But this is why it's not a one size fits all. Of course, mental health is more challenging to treat than a stent block, than putting a stent in the heart. Most individuals, you just stent that vessel and they can go along their way for at least a short period of time before another blockage occurs. But I can't answer that without saying that we need to have a doctor or a trained professional actually give that individual who has been found with an overdose enough attention to at least figure out what has contributed. I hope that's not too high of an ask in a modern medical care system that spends 18% of its GDP on medicine. And yes, Matthew Perry, ketamine plus buprenorphine. It wasn't ketamine alone, but absolutely there can be an overdose. Um, I take opioids for chronic pain by a pain management doctor. I'm not addicted. I'm dependent. I do not get high. Well, I'm happy that you're in that category, and I hope that you continue to find relief from your opioids. So many great comments. I want to mention Laura's comment here. Ketamine does not help with pain. It depends on what form of ketamine you're getting, depends on the dose and any adjuncts. Ketamine is sometimes very powerful as monotherapy, but it has to be the right dose, the right environment, the right infusion rate, etc. So it's not always a one size fits all, just like how chronic pain itself does not manifest the same in every individual. Very good question. Jessica, good to see you. And I totally agree that any type of post overdose care absolutely depends on the substance used. How does a cortisone shot minimize pain or take it away? Cortisone is a potent anti-inflammatory. If unmitigated inflammation is causing pain, then a cortisone shot can deliver a high amount of that anti-inflammatory agent to the site of inflammation to help reduce pain. And I'm happy that Portugal has a better system than what we have in the United States. It's not really a high bar, but I'm happy that they have that. You are so well. I appreciate your kind comments. It's very, very kind of you. I hope that you can have a similar relationship with your doctor. Would you do a Q&A on ketamine? It has been life-changing for my treatment-resistant depression. I would love to do that. And very welcome, Janet. Disappointment and depression. Do you treat them differently? Well, Sheldon, yes, they have a shared underlying cause, but in the Western medical system, we have definitions to separate them. But it's not uncommon at all that so many of my patients with tremendous self-guilt, disappointment, frustration are depressed as well. And they are, I strongly believe, causally related. And I want to see Straight Talk's last comment. Some doctors are so unsympathetic to patients with mental health. So who do you turn to? I'm not sure if you've gotten a chance to see my videos on gaslighting, which is one way that a lack of sympathy can very tangibly affect the patient-physician interaction. I hope that I hope it's never happened to you, but I share some tips in there about bringing friends with you, taking notes, making sure there's eye level that's not too up, too down, so that you're minimizing the power differential, and always having the courage and empowerment to ask for what the doctor's plan is for you to improve in your care. You're entitled to ask about your plan. It's what you're paying for. It's their job. But I know that when there's a power differential, it's so difficult to think straight or to have those ready on the tip of your tongue, which is why practicing, not like someone's out there to get you, but practicing so that you're prepared can be invaluable. I wish you all the best for the rest of the weekend. If you've learned something new, please do share with others. Please remember that you have more power over your health than you've ever been told. Ibogaine, Dean, yes, we talked about it a little bit briefly on our last live stream. It's a powerful psychedelic and might play a strong role for opioid addiction in the future. We're not there yet for the research, but anecdotally seems to be incredibly powerful. I certainly hope that everyone has a good rest of the weekend. Till next time.